The presenting symptoms of pneumonia have a broad differential diagnosis. In newborns, bacterial pneumonia in the first day of life may be impossible to differentiate from transient tachypnea of the newborn or respiratory distress syndrome. Thus, these patients are often treated empirically for bacterial pneumonia. Depending on the history, bronchopulmonary dysplasia, foreign body aspiration, and chronic pulmonary disorders, including asthma, bronchiectasis, and cystic fibrosis, should be considered. Aspiration pneumonia should be considered in patients with oropharyngeal dysphagia, gastroesophageal reflux, tracheoesophageal fistula, cleft palate, and neuromuscular disorders. Anatomical malformations such as bronchogenic cysts and congenital lobar emphysema may also be considered as part of the differential diagnosis. A thorough history and physical examination is often sufficient to diagnose uncomplicated pneumonia. When asking about history, the onset of symptoms and nature of the cough, such as whether it is wheezy or paroxysmal, can help narrow the diagnosis and rule out anatomical malformations and exacerbations of underlying chronic pulmonary disorders. Non-respiratory symptoms such as lethargy, irritability, and poor appetite can help determine illness severity. Verification of immunization status is important to rule out serious pathogens, such as Bordetella pertussis or Haemophilus influenza, and influences management decisions. Physical examination should include an assessment of vital signs, particularly the presence of fever and tachypnea. Pulse oximetry should be performed in all children with suspected pneumonia to assess for hypoxemia. A thorough pulmonary examination is necessary for evaluating pneumonia and can provide clues to the etiology. Bacterial pneumonia often presents with lobar pneumonia. Examination of the affected lobe will reveal rales or diminished breath sounds on auscultation and dullness to percussion. Viral pneumonia, however, is often a diffuse process with low-pitched wheezing heard throughout the chest. Rapid nasopharyngeal testing for viral infections should be performed in the evaluation of pneumonia, as it can decrease the need for additional diagnostic testing and unnecessary antibiotic use. Other studies, including chest radiographs, blood cultures, and complete blood count, are not necessary for mild lower respiratory symptoms consistent with pneumonia in children well enough to be treated in the outpatient setting. Indications for obtaining chest radiographs include hypoxemia, significant respiratory distress, failure of initial antibiotic treatment, and hospitalization. Severe pneumonia is an indication for other testing, such as blood and/or sputum cultures, viral testing, complete blood count, and acute phase reactants to help identify pathogens and monitor treatment efficacy.